Hi, I'm Pratima Chowdary. I'm the Chief Investigator for the BMA study, and I work as a consultant hematologist at the Royal Free Hemophilia Center. I've been involved with the study for the last 3 years, and an exciting part of this study is we are trying to achieve normal factor IX levels. There's been a lot of discussion if we need normal factor IX levels, but I have a personal view about this in that gene therapy is a major step for most patients. And if they're going to undertake gene therapy, there are several inherent risks with gene therapy. We might as well give them the full advantage of having normal factor IX levels. I do appreciate this is more of a philosophical discussion rather than a physiological discussion. Moving on to the BMA study. I think it is one of the second generation studies in the hemophilia B gene therapy space. When I mean second generation, it essentially uses a factor IX gene that is modified with the gain of function mutation, which is the PAD1 mutation. This is now being trialed in at least 3 studies, and the BMA study is one of them. In addition, the BMA study has also changed the vector so that there is increased efficiency in transduction. The synthetic vector that we use in this essentially has got a transduction efficiency that is about 4 times higher than your standard AAV8. In addition, we've also taken into account the management of transaminitis. Because of the increased efficiency, we had concerns that transaminitis may be higher. And more importantly, we also know that once you have transaminitis, the outcomes in an individual patient can be quite poor. So we had a transaminitis strategy that was planned upfront. If we look at the trial design, is there anything special about the trial design? We've used an adaptive trial design because we wanted to find the right dose of vector that would give us the normal factor IX levels. Essentially, we had identified 3 dose cohorts very early in the study, but because of the dose response relationship we had seen in the study, we had to add in a couple more cohorts halfway through the study. The key exclusion criteria in the study was the presence of neutralizing antibodies to the vector itself. As mentioned, the transaminitis strategy include a combination of upfront prednisolone early in the study, but later in the study, we added in tacrolimus for some of the patients. At dose level 1, we gave 4.5 E11 vector genomes per kilogram, and with this dose level, both the patients achieved factor IX levels which were within mild hemophilia range, just below the lower end of normal. Both of them also received a prophylactic immunosuppression, and neither of them had any transaminitis. Patient 3 and patient 6 were dosed at 1.5 E12 vector genomes per kilogram, and this is just a reflection of the adaptive trial design. We had several learnings from both of the patients which have made their way into the trial protocol. With patient 3, on a decreasing dose of prednisolone, he developed a transaminitis. We were slightly delayed in the diagnosis of breakthrough transaminitis, as there was some discussion about the possible influence of alcohol in the as a cause for the raised ALT and AST. Once we realized that this was vector related, we restarted him on prednisolone. As we were quite keen to preserve the expression of factor IX, we introduced a tacrolimus for the first time. And indeed, the patient did extremely well and has a factor IX level, which is well within the normal range 18 months into the study. Patient 6 received 1.5 E12 vector genomes per kilogram, as the response in patient 4 and 5 did not result in a normal factor IX levels consistently. This patient had a response which was quite disparate from the response in patient 3. Very early on, he had high factor IX levels, and we were quite concerned about the potential risk of thrombosis in this patient because of his age and other comorbidities. We had a risk assessment undertaken, because of which he was initiated on prophylactic anticoagulation. which was stopped after he had rolled over into the extension study. Unfortunately, when his prophylactic anticoagulation was stopped, he did go on to develop a thrombosis of an arteriovenous fistula, which is quite common even in your hemophilia patients. Patient 6 also went on to receive 1.5 E12 vector genomes per kilogram, as the response in patient 4 on 5 wasn't within the desired target range. In this patient, as early as week 3, we realized his response was not concordant with patient 3, but importantly, we were concerned by the elevation of factor 9. We were well aware of the impact of steroids, and as such, a multidisciplinary risk assessment was done, and he was initiated on prophylactic anticoagulation. Through the trial, when his factor 9 levels stabilized around 250, we had a discussion with him about the benefits and risks of long-term anticoagulation, and a decision was taken to stop the anticoagulation. A few days after stopping the anticoagulation, he developed a thrombosis of his arteriovenous fistula. Thrombosis of arteriovenous fistulas are quite common even in patients with hemophilia who have an underlying bleeding disorder, and is particularly higher in the renal group of patients. As such, he's just now on a long-term prophylactic anticoagulation in relation to his age and other risk factors. As I mentioned, the dose level 3 was sandwiched between patient 3 and 6, and at this dose level, the expression of factor 9 was a little bit better than dose level 1, but not particularly within the desired target range. We had developed further understanding of transaminitis and how best we might use a combination of prednisolone and tacrolimus. When we moved to dose level 4, the first patient received a prophylactic prednisolone and tacrolimus. This was based upon our experience from the previous patients. He did extremely well, but 2 weeks after stopping his prophylactic immunosuppression, he had a recurrence of his transaminitis and responded to reintroduction of his immunosuppression. What we learned after patient 7 was that tacrolimus and prednisolone is effective for preventing vector-related transaminitis, but we also learned that the duration is important if we want to completely prevent a transaminitis. Patient 8, 9, and 10 have been dosed at a 9.75 E11 vector genomes per kilogram, and their week 3 level was well within range, and we expect the month 6 level to also be within range and probably towards the slightly higher end. I think in summary, we can be quite confident that FLT180A results in factor 9 expression, and at the right dose level, we can see factor 9 levels within the normal range. The adaptive trial design was very helpful in identifying the right dose level to achieve normal levels of factor 9. We also learned that transaminitis is an important factor that has an impact on the factor 9 expression. From our experience, we have learned that a combination of prednisolone and tacrolimus seem to be quite effective in inhibiting on controlling transaminitis that happens during the highest risk period, but also seems to be very effective in getting a response even with late recurrences. I think the trial data is very promising to develop a phase 3 pivotal study.